All right, welcome everybody to our last address of this year's programming for the Future Directions Forum. Really excited to introduce our speaker, Dr. Miya Barnett. As researchers and members of our communities, we interpret the widely known proverb, "It takes a village to raise a child," as signaling an idea that it takes an entire community of people to provide resources and engage in positive social interactions with youth to ensure their healthy development and well-being. The work discussed by today's speaker essentially poses a question: who among us has the ability to be involved in providing resources that meet the mental health needs of youth in our communities? Traditionally, the answer to this question resulted in thinking that service provision should be restricted to a privileged few licensed providers, and only after years of training and supervision. Arguably, such an approach, in combination with decades of thinking dedicated to developing services and estimating their effects, has resulted in many service options that appear to bring about significant changes in health and well-being. Yet, the reach or accessibility of these services often falls far short and stops at a privileged subset of youth in our communities who have the means to access effective care. It is for these reasons that researchers like today's speaker are posing bold questions to those in the mental health service community. Does the evidence indicate that a larger portion of our communities can share in the responsibility of meeting the mental health needs of our youth? The data are compelling, and they point to a variety of ways in which members of communities, often with little to no training, have the capacity to serve roles that target crucial nodes of the service delivery process, from increasing a community's awareness of service options, to improving engagement among clients already receiving care, and even to serving frontline service delivery roles as direct service providers. I'm excited about today's address because in her Future Directions article, our speaker not only provides us with a framework for thinking about lay health worker models of service delivery, but also points us to carving paths or lines of research that seek to optimize the effects of this potent, community-centered approach to thinking about reducing disparities in access to effective services. Everyone, I give you Dr. Miya Barnett.
Well, thank you for really one of the nicest introductions I've ever had. That was really lovely and got me excited to do this talk and explain my work. So it was an honor to get to write the article, and even more fun to think about how to reflect on it in a talk. And I'm grateful that people were flexible with scheduling, as well as I was not able to do the first time slot we had. So I'll just start quickly with disclosures and say I don't have any conflicts of interest to disclose, and that this work has been funded by the NIMH, but reflects my own opinions, not those of the NIMH. So we're going to zoom out to the whole world right now and talk about mental health disparities. And what we know is that 72 to 93% of individuals who need treatment in low and middle income countries do not receive it. And estimates used to estimate that close to 240,000 additional providers were needed to meet global mental health need. And I just want to stop here for a minute. I'm going to say this probably a couple of times in the intro and say, and all of this was before COVID, right? And so all these estimates are likely underestimates for the place that we're at in the world these days with the mental health impacts that COVID has had. So the World Health Organization came up with the Mental Health Gap Action Program starting in 2008, which was really looking at what steps would be needed to meet this large mental health gap in the world between those who need services and those who are able to receive them, and had many steps that included involving non-specialist providers, including lay health workers in treatment. And since that point, there's been a lot of wonderful work done in low and middle income countries, and I'm going to talk about that a little bit. But more for my work and for where we want to be thinking about today is how does this apply to disparities in access in the United States? So those numbers sound striking. And I think there could be a place coming from a more resource country that you think that's not us. But what we know in the United States is that children specifically, in keeping with where my research is at and where SCAP's mission is at, also have high rates of unmet mental health needs. And again, this study is from 2019, and this is before the COVID pandemic and all of the exacerbation and access to mental health needs. And what we see is that it really does vary geographically. And when I saw this map, one thing that came to mind was, how does that map on to places where there are larger percentages of people of color and families of color and children of color? And when you overlay those maps, this is not scientific, but just of interest, you really do see greater disparities in states that have a larger percentage of children with who are children of color. And it makes you think, what do we need to be doing here in the United States? And the answer is obviously many different things, right? But there are just states where the majority of the population aren't being having their needs met. So recently, work has really started to point to this idea that we start learning from low and middle income countries and the work done. And it's really a mutual capacity building. It's understanding across fields, and that there are many lessons on how we could be addressing our own disparities. And in fact, again, post-COVID, if you want to say post, we are recognizing that the designation of low and middle income country versus high income really can in some ways be meaningless. Even if you look at the way that countries were impacted, which countries had the highest mortality rates and what that will do to trauma within the country, it doesn't align perfectly with where more resources are, right? And so in global mental health, the push now is that we should really not be thinking of low and middle income country and high income countries as dichotomies, but that there are solutions that should be deployed across settings. So low and middle income countries, like I said, were more likely for longer to be using lay health worker models, working with members of the community with no formalized mental health training to start to deliver these interventions. And this idea around task shifting, or the idea that some tasks would be with less trained professionals and more intense tasks with more trained professionals that are fewer, started more in physical health, but has extended recently into mental health. So in 2018, I conducted a systematic review on lay health worker mobilization in the United States and low and middle income countries to see what the state of the field was then. The rapid increase in interest in this area makes me know that this is already outdated, but probably the trends have continued. So what we saw in this is, as I said before, many more studies have been done in low and middle income countries with lay health workers. And of those studies, we looked at what kind of mental health intervention was being delivered. Was it an evidence-based treatment protocol or based on an evidence-based practice, so adaptive, but generally based on that? Or was it a novel new intervention? And what we see is two trends. One, just more research is being done in low and middle income countries. And in low and middle income countries, they were more likely to be having lay health workers involved in delivering evidence-based treatments, opposed to in the United States, it was more likely to be a new intervention, which is a long and complicated debate for another day. But we can recognize that there are different roles and challenges in the US and other high-income countries around what role lay health workers are considered to be appropriate to do. what the licensure and certification requirements are for evidence-based practices, and what implementation supports are needed to make this happen. Because it is different when you are working within a context of more regulated, higher levels of professional providers, what roles we're going to have individuals do. And it actually, what I've reflected on a lot with my colleagues in global mental health, many of whom who have moved to do some work here in the US, is that there's sometimes greater complications here in the US regarding what we're going to do. So we'll get into that more. So I proposed a conceptual model of what the role of lay health workers could be in addressing mental health disparities, recognizing that there are two areas that can drive disparities. One is related to the supply of providers, and that often, especially for individuals who from minoritized communities, especially those who speak other languages besides English, there is an inadequate workforce. And so there is a real lack of culturally and linguistically competent services in the United States, and that's a huge reason for disparities. And also on the flip side, there's demand drivers of disparities. Even if you have them, is there going to be stigma around receiving that mental health care? Do the communities that you're targeting to get mental health services know about those services? Do they have they had adequate outreach and being brought in? Do they feel comfortable? And what are the logistical barriers? Where are these services being offered? At what times? What's the transportation? What are the structures in place to make that happen? And the lay health workers can really play different roles in addressing supply because they're more likely to be bilingual providers or multilingual providers. They can have all sorts of specialized roles that can impact the supply, which I'll get into in a bit. And they can do this outreach. They can help address barriers, and they can reduce stigma within communities with the hope, obviously, of reaching more mental health parity. So I actually get phone calls and emails quite frequently of individuals saying, I want to do a community health worker, I want to do promotoras, I want to do lay health workers or peer support specialists, all these words that are different forms of lay health workers. I'm going to start doing that. And so like, what do we need to do? And I always start and say, what do you want them to be doing? What role do you see as the point of entry? And even that is such a big question that people are like, what are you talking about, lady? And so I always think it's important to look at the types of roles you're talking about and what is needed to be impacted. So in the United States, the most frequent roles that are usually part of a community health worker, lay health worker, wellness navigator, family navigator, again, there's a lot of words here, is around outreach and navigation. So individuals that are in charge of doing types of outreach at health fairs, for example, or within their community, helping with screenings and providing referrals, really serving as a bridge to service and helping families navigate very complex systems to make sure they're linking with the appropriate mental health care. Another role that individuals take, and I see this often more within parent support models, for example, like we see in New York State, is a more auxiliary support where there is an individual who is working with both professional providers, but also a peer support or professional or parent support partner on just navigating what it takes to be involved in these mental health services, some case management, addressing barriers to care, and possibly promoting adherence and engagement and comfort within the mental health system. And then on the full supply side more are these models where you are having like health workers serving as the primary providers. They're the ones who are directly delivering mental health interventions, which is the model that we're more likely to see within low and middle income countries, either in stepped care, in which they would be providing prevention level CBT for anxiety and depression, for example, like Vikram Patel's group does in India, and then referring more severe cases to the professionals, or delivering the treatment. And even though this is possibly more complex in the United States, there also has been a lot of work done in this area of having like health workers be the treatment deliverers, more often in the prevention realm. So when Dr. De Los Reyes invited me to write a paper with some of my wonderful junior colleagues, students and colleagues, it was really a wonderful time to revisit this model that I developed in 2018 and say, what needs to be done? What do we need to know about this? And I embedded it and combined it with the implementation science framework of RE-AIM, which looks at reach, effectiveness, adoption, implementation, and maintenance as 3 categories you want to be considering when developing interventions and planning for their scale up. And I took the opportunity of writing this paper to really think through, where are we at as a field within these different domains, and where do we need to go? And today in my talk, I'm going to go over each of those domains and my thoughts on that and where I think we are as a field. And I'm going to put it within the context of a case example of work that started in Miami and has continued there. And also I have been working on as part of my K award here in California. So when I was on internship, I had the wonderful opportunity to work within at the University of Miami in the Miller School of Medicine. Shout out to my colleagues there, who was approached by an agency within Little Havana called Connect Familias, which was a natural helper or community health worker, lay health worker. Again, there's a lot of words for this workforce organization that was really working on enhancing health equity within their community. And what they were seeing and hearing from families living within the community was that many of the immigrant Spanish-speaking families had concerns about parenting, but were not accessing the types of parenting programs that felt helpful. And so they wanted a natural helper program to help increase linkage to PCAT. So again, in collaboration with this wonderful group and my colleagues at University of Miami, we developed a training program and a natural helper auxiliary program to PCAT, in which the professional providers would continue to provide PCAT, doing the assessment and the treatment and consultation with the natural helpers, while the natural helpers were in charge of doing outreach within the Spanish-speaking immigrant population in Miami, care coordination, providing emotional and logistical support, and making sure families were really hitting all those engagement, getting over all the engagement challenges they might have, to enrolling, adhering to home practice, and eventually graduating. The points where we often see disparities within parent-child interaction therapy, or PCAT. And like I said, this case study I'm going to mix throughout when I'm talking about it. I moved to California after my internship and was lucky to receive a K award from the NIMH on how this model could be implemented within community mental health settings, opposed to more of a university setting. And so some of our learnings will come from Miami, and some of them will come from California. So let's move to REACH. And my question with REACH is, do lay health workers increase reach of evidence-based practices by impacting supply and or demand? And I feel like sometimes this is a question that feels so simple for people, they can't even believe that I'm asking it, because that's the whole point, right? Is that if you have lay health workers, more families will be reached. But what I'm here to tell you is we might have to think about it a little bit harder than that, and we should always test those assumptions. So our first trial in Miami was just looking at what happened after we introduced the natural helpers in Little Havana to PCAT services. And over a period of time, what we did see was that those served by natural helpers had a lower income and greater racial and ethnic diversity than the population being served within the PCAT clinic, typically. And so that is promising. This was not a randomized controlled trial. This was just an open trial. But this was a real both and situation. And I think this, again, is where we need to reflect on it, because what we found quickly, and by we, I mean people who continued the work after I left to California, was that as the natural helpers were making these referrals, it was still hard for families to get to the medical campus. And in fact, what we needed was a greater supply of PCAT along with the natural helpers. And so this is a case where supply and demand increased together. Natural helpers were able to help more low-income and racially and ethnically diverse families, and specifically Spanish-speaking families, get to PCAT. But what do you need? You need Spanish-speaking therapists to actually be able to deliver it. And what works best is if you embed clinics had centers that then led to clinics opening up in Little Havana, in Overtown, and in Homestead, which are high need areas of Miami. And what happened when I went to do this work in California? Well, very similar concerns. And just quickly checking, is my internet okay? Because I got a little internet unstable. Okay, good. When I first approached community agencies about this project, people were very excited, because time and time again in the work that I was doing as a PCAT trainer and somebody who studies how PCAT is implemented without lay health workers, what we would hear is there's a real issue with referrals. We don't get enough kids who are in that 2 to 7 age range. It's really hard for us to get our therapists like stocked up with enough clients that they can get them go through the certification process. And I was like, oh, genius. I have a model for this. I know what to do. I know who can be doing this outreach. And NIH thought it was a good idea too when I proposed this. And then you go to do something, and this is how science always works, right? And I was like, okay, so we're going to have in California, promotores de salud promote this treatment out in the community, be doing these community outreach. My community agency said, whoa, whoa, whoa. We don't have enough Spanish-speaking providers. We have a long wait list for our Spanish-speaking families. And in fact, please don't do any more outreach, because it looks bad for our agency to have more families who aren't getting served and longer wait lists. And I said, oh my goodness, like, oh no. And so this is community partnered research. This is implementation science. And so we really had to work together to talk about, like, one, the agency started to realize, oh, we are actually perpetuating some disparities here. We need to be training more of our Spanish-speaking clinicians in PCAT. And also, even the way that they were introducing PCAT at the phone screen, most Spanish-speaking families were not choosing the evidence-based practice. They were choosing like play therapy. And this is consistent actually with some of our early work in Miami too, natural helpers, if you give people all the choices, oh, why would I want to do that thing that sounds so hard where I'm like learning behind a mirror and being watched and having to do homework every week. And what we found was do the phone screen, agree that you're going to see this family, and then have the promotora talk to the families while they're on the wait list to keep them motivated, to keep them excited, and to really learn about this intervention from somebody that they're building trust from. And that's where we started to see, now we're getting people saying, yes, I want to do PCAT, and it's not increasing the wait list, it's actually helping to alleviate the wait list a little bit, in that families are feeling like they're not waiting for so long because they're talking to a promotora. So, but all that being said, it really points to your reach is always going to be limited when you're not having the lay health workers be the people providing treatment by how many people actually can. So what lessons have I gained from this for future directions for me to maybe do one day, but better yet, one of you all to take on and do, is that it's really important to have systems thinking when you're developing a lay health worker model. If you're going to be developing something to address stigma, to screen, and to make sure that individuals in the community are getting more services, you need to make sure that you have those services available as well. And on the left of this picture, you see some squiggly lines, which is more a recommendation to read a paper and read what my brilliant colleague Chris Sheldrick did, who did simulation modeling on a screening program that sort of addresses lay health workers, but not directly, where he ran different models based on what the likelihood is if you do referrals, that it's going to how it's going to impact your wait list, and then how that could impact the system, like people dropping out, people dropping off the wait list and not getting services, or even therapists leaving because they're feeling overtaxed and overburdened. And it's just a methodological approach that makes me really excited as somebody who's more likely to be doing the direct intervention or implementation work, to think, you know, if we're doing lay health worker work, we should be thinking about, are we actually able to increase reach, and what else has to change within the system to make reach happen? And what role is the most appropriate for our lay health workers to be doing, including possibly really bringing more of those task sharing models into the United States if we don't have an adequate workforce, even though the push to date has really focused more on lay health workers doing more of the bridging to services. Okay, so that's reach in a nutshell. Let's see if I can. What about effectiveness? Again, an important question to ask. Are lay health worker models of care effective? And back to 2018, so recognizing this is dated, at that time there had been 27 RCTs of lay health worker delivered interventions or supported interventions, and 18 were found to be effective within an RCT. Important to note, again, we were looking sort of what role are individuals taking in this? Are they delivering the intervention? Are they doing case management? The two trials with case management, more of a bridging role, were non-significant. And the most robust evidence was coming from low and middle income countries in settings where it was lay health workers delivering interventions, which could mean a whole lot of things, but most importantly means that there's work left to do to make sure that if we're introducing a treatment model, that we are making sure that it's actually having the effect we want it to. So again, this is pre-press, but we're really hoping we'll be in a special issue coming up soon. We did a randomized controlled trial of PCAT with natural helpers. This again is my wonderful colleagues in Miami. It's really fun to get to start projects and then watch what people run with and do over the years. And this looked at assigning families either to have natural helpers or just do time-limited PCAT, and what's going to happen with engagement, attendance, retention, parenting skills, and child behaviors. So I love research because all of your assumptions can get tested a little bit and it leaves you scratching your head. First of all, I just want to go over, before I get to those results that I just teased you with, just want to point out this was a very diverse sample that had minimal exclusion criteria. So there was families referred from Department of Child and Family Services, children with comorbidities, including autism spectrum disorder, families who were Spanish speaking and English speaking, and low SES. So what do we see? Well, we saw small and non-significant findings on our engagement outcomes. We found small to medium, and the only one that was trending towards significant was discipline skills. And the place that we found significant findings on a broadband measure and on behavior observation of child compliance was the place that we found the biggest results, which were small to medium on child behavior problems. And this was fascinating to me because, for one thing, as a PCAT researcher, it is actually really hard to get improved child outcomes in any sort of adaptation of PCAT. It's a really robust treatment. And if we were expecting to find differences, I thought it was going to be around engagement and possibly more around parenting skills. And so I continue to grapple with these findings, which I find exciting and fascinating. So where do we need to go for our effectiveness research in lay health worker delivered treatments? Well, we need to know what types of roles are the most effective. Is it the treatment that's being delivered or the role that a lay health worker is taking? And what is the comparative effectiveness with professional providers, which is an area of research that has not had a lot done in it, but is important because with all that we do with lay health worker models, we want to make sure that they are decreasing and not increasing disparities. If we find that we have still better outcomes with our professional providers, but are mainly focusing on having already marginalized, minoritized populations seeing a workforce that is having worse outcomes, is that only going to make disparities worse, or will it still be better for public health because people are more likely to get treatment, if that makes sense? So those are the big questions that we have to be asking. All right, moving to the more implementation side of our lay health worker work, what leads lay health workers to start to do evidence-based practices? So in Miami and in Santa Barbara in California, what we found is that if you train lay health workers in these models, they are able to adopt it. They learn it and in fact have very positive attitudes, is what we have found, towards the different skills. Their attitudes improve towards practices they don't find as favorable at the beginning, like selective attention and timeout, and they're able to use to model the different child-led skills that we teach parents to do. And so adoption of the practices is good, and anecdotally what we hear is lay health workers talking about, like, now I use this with my family, or I've been practicing this or telling my family about it in multiple countries, actually, so that they want to now do PCAT as well. So they're very good at their job of enhancing and promoting these practices. But there are identity factors that are going to impact adoption, and that is something that we're grappling with here. So I just want to highlight some of my students' work. My wonderful junior colleague, JC Gonzalez, recently published Lay Health Workers' Perspectives on Engaging Latino Fathers. And this really gets into questions around who lay health workers feel comfortable working with. And if the main thrust of a lot of their work is we have shared identities and we have shared experiences, what does it mean if they have some aspect of their identity that is different than the person that they're working with and their comfort level? So JC did a great job hearing lay health worker perspectives on how positively they feel about the need for fathers to be involved in parenting interventions, but how many concerns they have about their own personal effectiveness in doing that, and what their cultural role is, and cultural dynamics can be around mothers and fathers and family relationships. And so is it going to impact them? And then another wonderful student in our program, Ileana Flores, really focused on what leads lay health workers to want to be in these roles, what leads them to be promotoras, and then be interested in these interventions, and how much their own identity is impacted when they take on these roles. And back to JC's question, if many of the lay health workers were saying, well, it would be really nice to have male promotores instead to work with the fathers, but is there going to be adoption of that role within, are men more likely to take that role or not? So lots of interesting thoughts about who should be leading these initiatives. And I really point to a need for us to have a better sense of the role that identity plays in who is going to be the lay health worker, and take an intersectional approach to that, because it's very unlikely that you can have somebody from the exact same culture, gender identity, sexual orientation, socioeconomic class, all of that serving families. So we need to understand if this shared identity and social proximity is so critical to enhancing engagement, what components of it really are, and then what needs to happen within policy to help lay health workers adopt these evidence-based practices. So let me see how I'm doing on time. Pretty good. I'll go quickly. So for implementation, our next questions really are, what does it take for lay health workers to be able to deliver mental health treatments? And back to sort of the definition is lay health workers are individuals without professional training, but they do need training. They need often a lot of training and supervision, and sometimes that is what's lacking to make them feel supported and effective at their roles. And implementation strategies really need to focus on what content lay health workers need to be learning and what techniques work to help them learn that. So content-wise, I have had a lot of thoughts and great conversations around how much do we need to be focusing on working with individuals who sort of are seen as engagement specialists on different engagement type techniques. Do we need to be teaching motivational interviewing? Do we need to be teaching like how you overcome barriers? Or do we need to be focusing more on just the intervention, this is what PCIT is, and this is how you can share about this information with parents, but put it in your own words, make it make it actually fit for the family. And then technique is, you know, how often should these supervision or training sessions happen? Or, you know, what are you doing to promote learning, which tends to be a lot of role play and in-person learning. This photo here is just indicative of the work we were doing. So we launched our whole study. We had things ready to go, and then COVID hit, and this happened to a lot of us, right? And I'm going to be honest with you, I paused the study for a while because the promotores themselves were like, we don't like online things, so we don't want to do that. And I was like, okay, well, this is supposed to last a couple of weeks, so I think we'll be back to in-person soon. And obviously that didn't happen. And so then our training focus shifted, not to PCT, but just how do you do telehealth? And we tried again and again on Zoom, and they were like, we can't, you don't understand when we say how uncomfortable we are with this, like we need to do this in person. So we all met in a park and were masked and socially distanced and going around with their iPads that they were using, helping them very clearly, like, this is what I mean when I say like enter into Zoom this way, and this is how we're going to do it. And it was wonderful, but it was that in person was really important. And then they were able to then share their own discomfort with families and say, like, if I can learn this, you can learn this, which really helped because we found our Spanish speaking families were much more hesitant to be doing telehealth and were therefore not receiving services when they were really needing it for a long period of time. And I'm just going to quickly, this is a impossible to read slide, but point to the need to be monitoring and documenting how you're modifying your training and your supervision and your other implementation strategies for lay health workers. And there was recently a paper published by a colleague and myself around how to document this, because it's important to understand how things may be the same or different for our lay health workers in comparison to our professional providers that we're training. What content, like I said, needs to be covered? Do we need to be focusing more on those skills that we learn within our professional mental health training programs, also within training along with interventions? How long does that take? How much does that cost? Those are going to help us really understand what it takes to have a lay health worker be somebody who can be providing mental health services, and what is needed to really leverage this workforce. And in doing so, I want to just highlight the work of a really wonderful McNair scholar working in our lab, who took meticulous notes during every supervision session around what we talked about, what the family's concerns were, what the promotores were saying that they were doing, and then also how we were supporting and supervising them to make sure that their advice was in line with fidelity to the model. But the reason I put this slide up here is because I highly encourage everybody doing work with lay health workers to build in some time to improve your interventions, because your interventions will get better and with advice that you hear from lay health workers about, like, this is the way I explain this skill, or a family was feeling really confused about this, and I heard many insights that I learned just as much in supervision as I think the promotores did. So what I would encourage for future directions is to help understand what is fidelity to different lay health worker models, what level of strategies are needed for them, and how can we share knowledge around these implementation to improve it within the community and make sure that we're building in enough time to learn from the lay health workers who might have better insights on how to meet community needs than we ourselves may have already had. All right, I'm going to wrap us up here with maintenance. And I'm going to end a little bit on a sad note. This is the end of the project, which is the unfortunate thing that happens with many lay health worker projects, is that because there's not strong financing in place for lay health workers, when grant funding ends, these projects end. This is both a sad and a happy photo. It was a wonderful celebration. And as you see, we had an excellent team. And I leave you with this quote from one of our promotoras. We know the promotora works with love, but we also know that a promotora have needs. And one of the things that I find most discouraging when I talk about lay health worker interventions is if you're planning on solving mental health disparities by working with a workforce because they're free volunteers or cheap and just have so much passion for it, are you really reducing disparities, or are you exploiting a workforce that deserves as much respect and compensation as professional mental health providers, which also honestly is not even in the service of professional mental health providers in the way that we're reimbursed either, to say this work should just be done for free. And so I'm heartened these days by a real increase of focus on community health worker funding and reimbursement, but the amount of future directions on how to guarantee that we can be reimbursing, but providing and financing community health worker models and lay health worker models, but making sure that they're actually effective and back to re-aim, increasing reach, being implemented with fidelity, being maintained over the time is a huge task for our field at this time. And I'm gonna leave it at that so we can have a nice conversation now. And I just want to acknowledge my wonderful partnerships with my colleagues at the University of Miami and their partners at Connect Familias, my community partner at CALM and the Santa Barbara Promotora Network, my truly incredible Padres Lab, and the funding for these projects.
Thank you so much for the address. This is great. And I really enjoyed the discussion afterwards.